Okay. All right, let's go over just view these concepts just as a review of what we may have discussed in the past with the nervous system in general AAP, just to go through how that relates to what we see here in the heart. Going out? Okay. Thanks, Hannah. All right. Okay, so let's picture, let's say you're sitting in a boat in water. Okay? So you're in water, sitting in a boat, and in this boat is a really small hole in the bottom. And so water is leaking into your boat. Okay? And you have no way to stop the leak, but you do have a pump that when the water gets to be a certain level, you can pump that water back out. But water will always be leaking into your boat. Okay? Well, that's kind of like what we see here in these nodal cells of the heart. These cells are perpetually leaky to an ion, which is sodium. Now, normally, the inside of these nodal cells is a negative environment, and it has a negative charge to it. Okay, so normally, the inside of the nodal cell has a negative charge. It has a resting membrane potential of minus 60 millivolts, which you see on this picture. Do you remember what a resting membrane potential is? No? Okay. What's wrong with you guys? You're supposed to remember everything you're told, ever. Okay, so when we think of a resting membrane potential, when we look at the membrane, the cell membrane, okay, the cell membrane defines the border between the inside of the environment inside the cell and outside the cell. Does that make sense? So like we're sitting in a room, so the membrane would be like the walls of this room, right? So inside we have a certain environment. Outside there's another environment. And that environment is separated by the membrane of the cell. So inside the nodal cell, the charge of that cell is 60 millivolts less than it is outside the cell. Okay? That'd be like if it were, let's say, 30 degrees in here and 90 degrees outside this room. Okay? There's a 60 degree temperature difference. It means it's colder inside than it is out there, right? Same thing. The inside of the cell is more negative. It has a more negative charge than the outside of the cell by 60 millivolts. Does that make sense? So when the cell is at rest, the membrane is separating an environment that is 60 millivolts more negative inside the cell than outside the cell. So when the cell is not doing anything across the membrane, one side of the membrane it's minus 60 millivolts, the other side is, I should say, there's 60 millivolts difference between the inside and the outside of the cell. Does that make sense? So when the cell is at rest, more negative on the inside. Okay? But that changes very quickly because we have these channels that continually allow for sodium to leak into, oops, wrong side, sorry, continue to leak into the cell. Okay, so we have these leakage channels that allow sodium to move into the cell. So that means that there's more sodium outside the cell than inside the cell, or at least the inside of the cell is more negative, that sodium wants to go in. Okay, so this is following the law of passive diffusion. So if you have a higher concentration of one ion on one side of the membrane and a lower concentration of the same ion on the other side, the ion is going to want to move from high to low concentration all the time until both equal out. Okay? Does that make sense? Okay, so passive diffusion. So we have these channels There are sodium channels that just allow sodium to leak into the cell. Just like water leaks into the boat from the bottom because of that hole. Make sense? So as long as there's a hole, the water is going to be coming into the boat. As long as there's a channel, sodium will always want to move into the cell. That's why shortly after we hit the resting membrane potential here, you see how we get more negative? More positive? See how we see a positive movement? That's because sodium is leaking into the cell until we hit minus 40. Now, this was minus 55 for neurons, but it's the same idea. Remember threshold? You remember the concept of threshold? It's this voltage that when we hit it, then we see an action potential. Remember, it's like flushing a toilet. So if I push on the handle of the toilet, but I don't push with sufficient pressure to flush it, it's not going to flush, right? But if I push with sufficient pressure, now the toilet flushes. If I push twice as hard on the handle, is it going to flush twice as fast or twice as much? No, it flushes the same. So as long as you reach threshold, you're going to get an action potential. Now, remember, an action potential is where you see a rapid depolarization. What's happening is you are opening up these voltage-gated sodium channels. Where is it now? Well, these are calcium channels in this case here. Calcium carries a positive charge, okay? So after sodium leaks into a certain point where we get threshold, now calcium, bless you, now calcium rushes into the cell, and calcium makes the inside of the cell more positive. Okay, instead of sodium, we have calcium rushing into the cell, making the inside of the cell more positive. So we see a rapid depolarization. Okay, we call it depolarization because it goes from being negative on the inside now to positive on the inside, or at least neutral, about zero in this case. Okay, so we take away the difference between the inside and the outside of the cell. Then we open up some potassium channels. We push potassium out of the cell, and we push the positive out. That's like pumping the water out of the boat, and so then the inside of the cell becomes more negative until we get back to our resting membrane potential. But it just sits there for a little bit because then those leaky sodium channels are going to open right back up and allow sodium to come right back in. Okay? So these pacemaker cells are constantly leaking in sodium till they reach threshold, boom, action potential, which means muscle contraction, and then it resets itself, and then it's leaky again, and then boom, hits threshold, and then we get another action potential, which means another muscle contraction. Okay? So these cells are spontaneously firing, they're spontaneously depolarizing because sodium keeps leaking into the cell, causing the cell to reach threshold, which then causes the cell to contract. Okay? Does that make sense? Is anybody lost or needs that explained again?
So reaching threshold is the negative on the outside, trying to get positive on the inside. Say it one more time here.
Sure. Okay, so threshold is a voltage that it's specific to different tissues. So in the cardiac muscle tissue, threshold is minus 40. In neurons, it's minus 55. So it depends on what it is. But threshold is the voltage when, upon reaching it, it leads to an action potential of that tissue, which means that you get a sudden surge of a positive ion into the cell, making the inside of the cell less negative and more positive. Does that make sense?
Yes.
Okay. And if you need me to explain more, I can. Tony. Does the sodium gate close? Yeah, they're not showing it here, but I'm guessing that once we get, yeah, it says here, fast. So when we hit depolarization, you can see here that we cover up that sodium channel. So
that one has to close for the calcium.
It doesn't have to close, but it does.
Okay, so
It happens to.
so that the calcium can open.
Right. See, but the idea here is that at rest, we're at minus 60 millivolts inside the cell, then this is perpetually open, so it's always allowing sodium to pass through. So then the calcium and the potassium channels are closed right now. These are voltage-gated channels, which means they only open when you reach certain voltages. So when we hit minus 40 millivolts, that causes this channel to close, and it causes this channel to open. When you zap it with a certain voltage, then we hit it. Then when we get to 0 millivolts, now that causes this one to close, this one's still closed, and then that causes this one to open. And then when you get to minus 40 millivolts, this one will close again, and then this one will open. Make sense? This is way more detailed than we need to be for the test, but I'm just showing you how this works so you understand it. Because if you don't understand the workings behind what's going on, it makes it more difficult to understand. So.
Are these nodal cells like located everywhere?
No, only in the sinoatrial node and the atrioventricular node. The rest of the cardiac muscle cells do not have this leaky property. They sit at a resting membrane potential until they get zapped, and then they depolarize. So they don't have the fluctuating. Voltage between resting membrane potential and threshold. They sit here at minus 60, and they just wait. And then when you hit them with an action potential, they get shot up to threshold right away, and then they depolarize. So they don't have this leaky channel that allows for the resting membrane potential to continue to be disrupted, if that makes sense. Kim, you square, or do you have more questions?
No, I got the sodium linking into the cell part, and they have to be a certain level for each, based on each
Yes.
system that it's targeting.
Yes. Okay. What other questions do you have before we move on? We're okay? All right, so this happens in those nodes. Sinoatrial node, atrioventricular node, they both do this thing. Now the rate of depolarization is different depending on the sinoatrial or the atrioventricular. So like I said, the sinoatrial node has a faster rate of depolarization. So this is usually the one that establishes the rhythm of the heart. All right, I'm going to show this to you graphically here, and then I'm going to show you a video that will show you this in an animated format so you can understand it as well. All right, so when we look at the electrical conduction system of the heart, whenever we talk about this action potential generated at the sinoatrial node, that's when we hit threshold, okay? Threshold means that the muscle is going to be contracting. Okay, so you can see here that we have the action potential generated here at the SA node, and that spreads to the atria. Okay? Then you can see the next one down here, number 2, that the action potential is delayed at the atrioventricular node before it passes into the bundle. Then the AV bundle is going to conduct that action potential down into the Purkinje fibers, and then the Purkinje fibers are going to cause an action potential to be propagated from the bottom up. Okay? So I have some videos here, and I'll post them on YouTube for you too so you can see them. This one's a good one here on the heart conduction system. So I'll play that for you, and then this does a really nice job of showing it to you graphically. Hold on a second here. I want to make sure that we're getting... Okay, it's playing. Okay, so there's no audio with this apparently. So this is the sinoatrial node. You can see that's initiating the conduction. So this is influenced by those three factors here. So three factors that can affect the pacemaker area of the heart would be the autonomic nervous system, the thyroid hormone, and epinephrine. These are all going to essentially speed up the heart rate. Well, it'll be the sympathetic of the autonomic nervous system that would speed it up. Thyroid hormone is going to speed up the rate of contraction from the sinoatrial node and also the epinephrine. So it's initiated there in the sinoatrial node. You can see that it's passes across into the left atrium as well, but it makes its way down here into this node, which is called the what? Yeah, the AV node. Very good. And there's a slight delay from when it reaches the AV node and travels down into the bundle. The bundle is called the bundle of His by some books. And then it travels into the bundle branches. Then it reaches the bottom of the Purkinje fibers, and then it contracts from the bottom up. And then it all starts over again. So you can see the atria contracting at the same time, and then the ventricles will contract at the same time. So you've seen how that works? What's important here is just to understand how it is doing that, and then we're going to correlate it to the EKG or the ECG in just a little bit, which will be in the next video. So one thing that I want you to know here, because I know that comes at you, and I want to make sure that you're prepared for that question, is when the sympathetic division of the autonomic nervous system affects the heart. It's on, I don't know what page. What page did that first set of notes go to? Does anybody have them printed? Well, it's in section 19.5 on page 11 in my notes, but I have the whole works. There's under 19.5 in your notes, letter B, number 6. It says sympathetic stimulation to the heart increases the heart rate and the force of contraction. Okay, so just make sure that you're aware of how the sympathetic division of the autonomic nervous system affects the contraction of the heart. So it increases heart rate and force of contraction. Okay, because I know that you're asked that on the quiz. One of the things about cardiac muscle tissue is that it has a relatively long refractory period, which means that you can't stimulate another action potential here. So this is what it's showing you here. So if you look at skeletal muscle, there's a period after the depolarization, and the depolarization is shown by this blue line here. There's a period of time after this depolarization where you cannot have another action potential. That's called the refractory period, the absolute refractory period. So what you see here in skeletal muscle is that if you hit the muscle with the depolarization, as long as it has time to get out of that refractory period and go back and reset itself a little bit, you can stimulate another muscle contraction. And so what you see here in skeletal muscle is that if you have a strong enough stimulus, you can cause the muscle to get stuck in a contraction called tetany or fused tetanus. That's impossible to do with the heart because look at the size of this refractory period compared to the skeletal muscle. Much longer. So you cannot ever get the heart to end up here in a fused tetanus because of this long refractory period. The heart will always come back and relax a little bit before it contracts again, no matter how frequently you stimulate the heart. Okay, so now what we're going to do is we're going to look at the conduction system of the heart and we're going to put it on an EKG. Now, the first thing I'm going to show you is a video of what the EKG represents, or the ECG, what that represents, and then we'll look at how an ECG works as far as what the ECG is measuring. It's really hard for me to show you or demonstrate on a two-dimensional picture how the ECG is set up and what the ECG does, but when you see it in the video, it'll make a lot more sense of how the ECG is reading it. And then after that, I'll show you a little bit, I'll give you another demonstration or a visual so that you can understand kind of how the ECG works. Now you might be wondering, what's the difference between an ECG and an EKG? And the difference is one letter, ECG versus EKG. An ECG and an EKG are exactly the same thing. ECG is English or American, electrocardiogram, cardio with a C. EKG is German, cardio with a K. That's it, okay? So if you hear of an ECG or an EKG, both are the same. It's just depending on, I think a lot of people call it EKG, which is the German. ECG is the English or American version. So what I'm going to do is I'm going to show you this video that will tell you about the ECG relative to the conduction system of the heart. And then what we'll do is we'll look at, what we're going to see is why these are, what these represent. This P wave and the PQ segment and the QRS complex and the ST segment. We're going to see what that is. Has to do with the conduction and the contraction of the muscle. And then we'll look at how the ECG works and what the ECG is actually measuring. So let's go to this next video here. The cardiac conduction system and understanding the ECG. This one should have sound. It also has captioning.
The cardiac conduction system consists of the following components. The sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires. Electrical signals spread throughout the atria and cause them to depolarize.
So when the atria depolarize, that was shown here in that P wave. It went pretty fast, but that's what you saw here. So when the SA node is stimulated and it causes that action potential, it causes contraction of the atria, you see that as the P wave. Now, this is an upward movement, and the reason why it's an upward movement has to do with the direction of the electrical impulse. And so when we watch that next video, you'll see why we see the upward versus downward movements on the ECG, okay? But I'm just showing you that that's where that occurred.
This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole. The cycle repeats itself with every heartbeat.
Okay, so that was that one. So when you're looking at the ECG and what the ECG is doing, what you're seeing here is a measure of the electrical activity happening in the heart. So when the atria, when we see the action potential through the atria, that's the P wave. That's this upper movement here. When it's traveling from the sinoatrial node to the atrioventricular node, that's what we see as a PQ segment. When we see the depolarization of the atrioventricular node traveling down that bundle branch, that's this downward movement here called the Q. And then when we see the action potential received by the ventricles, then we see that as this big upward movement here. And as it's moving through the ventricles, it moves back down. And then as we rest in between the depolarization and the repolarization of the ventricles, we have this ST segment here. Okay, so we can see here that the first part, it has to do with the electrical changes that occur within the atria, and then when we get to the QRS complex, that is involving mostly the ventricles. So normally, what we see on an ECG is a nice, very regular space between the QRS complexes. You can see that these are well spaced here. What you're seeing here is a bundle, atrioventricular bundle block. So that's going to affect this slope that comes right before the QRS. Do you see that? How it doesn't drop until the very last minute here. So that's what they're talking about, that bundle block, that bundle of his, that it's not propagating through that normally. Second degree atrioventricular block means that it's so severe that the impulse didn't even make it to the ventricles. So we see depolarization of the atria, but it didn't make it down to the ventricles. See that? So it's like a skipped beat. It's a contraction of ventricles, repolarization, atria, nothing here. And then so instead of a heartbeat that goes thump, 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 we're getting thump, 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 thump. And then a third degree, you can see here we're really missing a lot here. So the degree has to do with how severe the blockage is that impulse is not conducting along the way. So here's a preventricular contraction that occurs here. These are all more advanced than we need to know here. So anyway, let me go back to this video here because I want to show you now how the ECG works, how an ECG measures what's happening. Now, in lab on Monday, for those of you who are with me here in class, I do have some devices that you can hook up to computers. I'll get a laptop cart ordered, and then what we'll do is we'll have fun with an ECG device. It's not a full-blown ECG, because a full-blown ECG, you've got to put these electrodes, you got all these electrodes you got to put all over your chest and your hands and your legs and stuff. This one, you connect it to your arms and I believe your legs, and that's it. So it's a more modified ECG, but it gives you the same information, and then you can hook it up to the computer, and then you can look at your own ECG information and get some information off of that. So we'll do that on Monday. So I wanted to give you some background information on how an ECG works and what an ECG is actually measuring. So what you don't realize with an ECG, if you don't know much about them, is what they're doing is they're measuring the electrical activity of the heart. They're measuring the movement of the electrical activity toward the recording device, which is that electrode. So the electrodes that you put on, as far as the ECG, they don't hurt, they don't do anything, they're just reading electrical information. Is the electrical information coming toward the recorder, or is it moving away? If it's coming toward, it's going to be an upward movement. If it's moving away, then it's a downward movement. So for example, if I were to have, I've got Hannah down that way, so she can understand it from my perspective. Let's have Randy. Would you mind coming over here and just sitting on this table here, this chair here? And then let's see. Well, I think we got a good enough space of people through here. So what I'm going to do is I'm going to grab this little apple here, okay? And so I'm going to say start, and then I'm going to say stop, and then I want you all to watch the apple, and I want you to have just make an observation, okay? So here we go. Everybody watch this apple, okay? Ready? Start. Okay, everybody watch it. Everybody watch this apple. Okay. Keep watching it. Stop. Okay. Now, Randy, what did you see? From start to stop, what did you see?
The apple getting smaller, moving away.
Okay, so the apple moved away from you the whole time. Okay? So you're an electrode, or you're a measuring device of the ECG, and what you saw, this apple represents an electric impulse. You saw that the electrical impulse moved away from you the whole time, right? Now we have Hannah over here. What did you see? It was coming towards you the whole time. So you both witnessed the same event, but yet it looked differently to both of you because you saw it moving away from you. So if you were an ECG reading device, what you would record is a downward movement because it was going away from you. What would you record? An upward movement because it came toward you. Now someone in the middle, what did you see? You saw both, right? It came, didn't mean to spit. It came toward you, then it moved away from you, right? So you'd see, what would you see as it came toward you? What would you see? What kind of movement? You'd see upward followed by a downward. So you see a little bit of both. You see that? You can go back to your seat, Randy, thanks. But that's how an ECG works. You've got all these devices that are recording the electrical activity of the heart, but from different perspectives. So now this video is going to show you what those different perspectives are so that you can understand what you're seeing. Now when you look at a 12-lead ECG, the leads look different. So let me see if I can just Google one so you can see it, and then we'll go to the video. So you can see what I'm talking about with the 12-lead. All right, so when you look at this picture here, you have lead 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. But they're all recording. This bottom one is a lead 2. This is sort of like your garden variety generic one. It just kind of gives you, just like a neutral representation of what's happening. But look at the difference here. Look at lead 1, for example. See these strong peaks that go upward here versus V2, where you mostly see a downward movement. See that? So it's because lead 1 and lead V2 are seeing different things. Here, V4, you see an upward movement followed by a downward movement, so similar to the people that were sitting in the middle. So what someone who can read these, a cardiologist would do, is they can look at this and they can look at the peaks and the valleys and they can see the bumps and the plateaus and so forth, and they can tell you if this is normal or abnormal, just like a person who reads music would be able to look at a piece of music and say, well, that's Happy Birthday, or that's Twinkle, Twinkle, Little Star, or something like that. They'd be able to look at it and say, oh, this person's got an old myocardial infarction, or this person's got a fresh myocardial infarction, or whatever. So what the ECG is showing you is the same activity of the heart, but it's looking at different pieces of the heart or different parts of the heart, and you're taking all that information and putting it all together to give you a composite view, a three-dimensional view of the heart from all angles, so that you can see if the heart is functioning normally or not, and if not, where on the heart the problem is. And they can interpret this and turn it into that, if you're skilled at reading these things. So it's actually pretty cool if you can do it. All right, so here's the video that I promised you. This shows you a little bit about the different leads and how they view the heart differently.
Electrical activities of the heart can be picked up on the skin via electrodes. An ECG machine records these activities and displays them graphically. The graphs show the heart's overall electrical potential or voltage as it changes over time during a cardiac cycle. The 12 leads of the ECG represent 12 electrical views of the heart from 12 different angles. The conventional 12-lead procedure involves attaching 10 electrodes to the body.
Okay, I don't know if you caught that, but if you look here at this part, they're showing you the views of the leads. So V1 looks at the heart like this, and then as you go through, V2, V3, so it's on the chest, so V1, V2, V3, V4, V5, V6, so you're going to be looking at the heart from different angles across the heart. So you'll see that, how the body's torso turns, and that is the view that each of those leads is viewing the heart from.
Views of the heart.
So take a look at that. V2, V3, V4, V5, and V6 is from the side.
The procedure involves attaching 10 electrodes to the body, 1 to each limb and 6 across the chest. There are 6 limb leads and 6 chest leads. The 6 limb leads look at the heart in a vertical plane and are obtained from 3 electrodes attached to the right arm, and left leg. The electrode on the right leg is an earth electrode. The measurement of a voltage requires 2 poles, negative and positive. The ECG machine uses the negative pole as 0 reference. Thus, the position of the positive pole is the point of view, and the line connecting the 2 poles is the line of sight. Leads 1, 2, and 3
so you
are
got the
bipolar.
eye here.
They measure electrical potential between 2 of the 3 limb electrodes. Lead 1 represents the voltage between the right arm, negative pole, and the left arm, positive pole, and thus looks at the heart from the left. Lead 2 sees signal movements between the right arm, negative, and the left leg, positive, forming the inferior left view. Similarly, lead 3 measures electrical potential between the left arm, negative, and the left leg, positive, looking at the heart from an inferior right angle.
Okay, so I don't expect you to memorize all these different leads and where they're viewing from. I just want you to understand the principle behind it and understanding that these leads are looking at the heart from different angles. Okay, that's what I'm trying to get across here.
Leads AVR, AVL, and AVF, or augmented limb leads, are unipolar. They use 1 limb electrode as the positive pole and take the average of inputs from the other 2 as the 0 reference. Hence, AVR looks at the upper right side of the heart, AVL looks at the upper left side of the heart, and AVF looks at the inferior wall of the heart. The chest leads, or precordial leads, view the heart in a horizontal plane. These are unipolar leads. The corresponding chest electrodes serve as the positive poles. The reference negative value is the same for all chest leads and is calculated as the average of inputs from the 3 limb electrodes. Depolarization toward a lead produces a positive deflection. Depolarization away from a lead gives a negative deflection. The reverse is true for repolarization. Thus, leads that look at the heart from different angles may have waves pointing in different directions.
Yeah, so what you're showing here is the AVR, which is viewing the heart from this view, is going to see mainly that the electrical impulse moves away from the heart, see? So that's why we see a big downward movement. Over here, lead 2 watches the electrical impulse move toward it, kind of like where Hannah was, so then you'd see a major upward movement there. Okay, so that's what it means. All right, so that's it for the ECG. The ECG is going to record the electrical activity of the heart, and then it's going to record it as a positive or a negative movement, depending. Okay. What questions do you have on the action potentials of the heart, of the reading of the action potentials of the heart, the ECG? What questions do you have for me regarding any of that information before we move on? And I believe that your lab activity for this week is an experiment, a virtual experiment with some virtual patients using the ECG. So you'll get a little bit more information and experience with that as well. And then, like I said, for us that are together in lab, on Monday we'll play around with the ECG equipment that I have, and we can play with that and check that out. That'll be fun. All right. So now what we're doing is we're looking at the cardiac cycle now. We're shooting ahead to section 19.8 in the cardiac cycle, and we're just looking at how the blood moves through the heart and some of the events that are involved with the blood moving through the heart. So this picture here, 1921 in your book, does a really nice job of putting it in 4 steps for us, and some terminology here. So when the atria contract, number 1, the ventricles are relaxed, they're going to fill up. Okay, so we know that the ventricular pressure is less than the atrial pressure, because if the pressure, was higher in the ventricles, it would want to move out of the ventricles, but it's, we're allowing the blood to move in. So then we get to this point here. It's called isovolumetric contraction. It's where the atria are relaxing and the ventricles start to contract. So now we see that the atrial pressure that the ventricular pressure is now exceeding atrial pressure. So what's it going to do to the blood? Which way does blood want to move? Into the ventricles or out of the ventricles? If the ventricular pressure is higher than in the atria. Yeah, it wants to move out. And actually wants to move back where it came from. So good thing we have these atrioventricular valves that close. What's this one called, this valve right here? Tricuspid, or the right atrioventricular, yes. So that's going to slam shut. So we're going to hear a thump when both of these are closed. And what's this one right here? The mitral valve. So when these valves close, thump. Okay, that's isovolumetric contraction. That means that the atria have now filled the ventricles and these valves close shut. The next step is ventricular ejection. Now that the blood cannot leave through these atrioventricular valves, it has no choice but to leave through the valves that allow for the blood to move through, which are these semilunar valves. So blood is going to move from the right ventricle to the what trunk? Pulmonary trunk through the what valve? The pulmonary valve, pulmonary semilunar, and then the left ventricle is going to eject blood through what valve? The aortic semilunar valve, yes. Okay, so you can see here, the atrioventricular valves are closed, semilunar valves are open. Then we get down here to number 4, isovolumetric relaxation. Now the ventricles are pretty much empty, they're going to relax. Now the blood is going to be essentially sucked back in through the atria. And so we're going to fill the atria now. The atria are going to relax. We're going to start to fill them. And then, again, here we have atrial relaxation and ventricular filling. We're back to where we started. So this is the step that we go through. These are the 4 steps of the cardiac cycle. Now, trying to see where they make a reference to this. We've got the thing down here. We've got the stroke volume, end diastolic and end systolic volume. I see the end diastolic. Oh, here's stroke volume. Okay, so we have some things that we measure, that we use to measure the cardiac activity. And one of them is the stroke volume. And the stroke volume is going to measure how much blood is being pumped out of the heart each minute. So, with each pump of the heart, with each stroke of the heart, each time the ventricles contract, how much blood is leaving the heart. And that is what we call the stroke volume. Okay. Now, when we see that the ventricles are contracting, when the ventricles contract, we call that systole. Systole. So when we're done with ventricular contraction, we call that the end systolic volume. How much blood is left in the ventricles after systole? Okay, that's the end systolic volume. When the ventricles are not contracting, when the ventricles are relaxed or starting to contract, but when the ventricles are relaxed and they're not contracting, we call that diastole. So when we reach isovolumetric contraction at the end of diastole, now we want to see how much volume is in the ventricles after diastole. So we call it the end diastolic end diastolic volume. These terms systolic and diastolic should look familiar. Where do you see systolic and diastolic? Blood pressure, yes, because you're measuring the pressure of the blood in the vessel during ventricular systole, when the heart is actively contracting and squeezing blood into the ventricles. That's your systolic number. And then that's going to be the top number. And then the bottom number is what's the pressure of the blood in the blood vessels when the heart is not contracting, when it's not in systole. That's diastole. That's the diastolic number. So when we see 120/80, that means that the pressure in the blood vessels when the heart is pushing the blood into the arteries, the pressure where you're measuring it in the arm is 120 millimeters mercury. And then when the heart is not actively pushing blood into the blood vessels, when the heart's at rest, as we would call it, that's the diastolic, that's your baseline. So that's why people say the bottom number is actually a little bit more important than the top number, because that's the overall pressure that's in your blood vessels at any given time. But remember this, always and forever, that the blood pressure that you measure is the blood pressure that is in that blood vessel that you're measuring at that location at that time. So it's conceivable that you can measure a different blood pressure on the right arm than the left arm, right? And the blood pressure could be different here, where you usually take the blood pressure just above the elbow, compared to at the wrist, right? Or at the ankle, or at the thigh, or whatever. So remember that the blood pressure that you're recording is the blood pressure of that location at that time only. Okay, you can't make assumptions about anywhere else. And be mindful of the time. I know we're jumping ahead because we talk about blood pressure later on, right at the end of this learning plan. But when I was working in our student clinic, we were trained to be able to dialogue with medical practitioners, because in Illinois, the chiropractors can be primary care providers. So we had to learn how to do everything. We had to learn how to take blood pressure, draw blood, do male and female sensitive exams, all that stuff. We had to learn all the stuff that a primary care practitioner does. And I had this, when we were working in the student clinic, we just took care of the students that went to school. We took care of each other. And I had this girl come in, and I was taking her blood pressure, and she always had high blood pressure. And I was like, well, okay, well, I've recorded your blood pressure like, 3-4 times, and every time I'm getting it, it's significantly high. It might be something you need to get looked at. So when I had my shift, it was in the afternoon, after she was done with work. So then she came in another time later, and she was just really angry at me. And the reason why she was angry is because she went and got her blood pressure checked somewhere else in the morning, and it was normal. And so she was just pissed at me because I told her that she had high blood pressure. Well, that was after work, and I can't remember what she did, but she did something that was very physically labor intensive. And she came to me right after work, and you could even see in her face, she was all sweaty. Her face was red. I mean, she had been doing something physically which is affecting her body. So of course her blood pressure is going to be higher. I didn't think of that, and I didn't consider that. And then when she came and told me that her blood pressure was lower when she went, I said, well, what time did you go? And she said, the morning, before work, all this stuff. I said, well, maybe you don't have high blood pressure, but maybe your blood pressure is elevated when you're coming to me after work. That was a light bulb moment for me. So think about that too. When you're taking blood pressure, always consider what the person has done before they come to see you. Because if they have high blood pressure, then maybe, and you might not necessarily be in charge of the timing of this thing, but I know nurses have a lot of influence in the clinics and stuff like that. Maybe the time at which you're taking the blood pressure is affecting the blood pressure readings. Something to think of. So it's always relative to the time and the place that you're taking the blood pressure. So just keep that in mind. This picture is a really cool picture if you can see it all at once. I'm going to show you what's on this picture, but we're pretty much going to put this to bed here. But what you see here at the top is the ECG reading, and it's color-coded. So you can see we have like this pinkish color, green, blue, yellow, orange, and then pink again. Okay, well, if you take the green and you follow the green down to here, you can see what's happening during this stretch of the ECG. You can see that that's atrial contraction and ventricular filling. And then here you can see this blue is the isovolumetric contraction, and so on and so forth. And you can follow that down here. You can even see what the pressure is in the different blood vessels or chambers of the heart. Okay? And you can even see the volume in the ventricles, depending on where you are. And then what's really nice down here at the bottom is that they give you a nice breakdown of what is happening at each step along the way here during the cardiac cycle. So it's a really nice graphic. And a lot of books do this. They'll stack them like this. And it does a nice job of just kind of tying everything together so you understand what's going with what. Okay, before we do that, let's just go through a couple things here. Okay, so if we jump now to 19.9, cardiac output, we're going to talk about some of the ways that we measure the pumping of the blood to the body, all right? So we have something called, where are we at? Let me go through this really quickly, and then we'll take a break. Okay, we have cardiac output. Cardiac output is bottom of page 20 of my notes. I don't know where that falls for you. It's section 19.9, letter A. So it's the amount of blood that's pumped by a single ventricle in 1 minute and is expressed as liters per minute. Okay, so what you're doing is you're measuring how much blood is being ejected out of the ventricles in a minute's time. So you calculate that by taking the stroke volume times the heart rate, and that's how you get it. So the resting normal heart rate is about 75 beats per minute. I say that's a little on the high side, but what the heck? Well, yeah, 60 to 80, so I guess that's about average. 75 beats per minute. Normal stroke volume is 70 milliliters. So if you calculate that, the cardiac output is 5.25 liters per minute. So that means that the ventricle will pump out 5.25 liters of blood per minute. So that's pretty significant. Yeah, it's pretty cool. Now, one of the things that affects heart rate are called, or the factors that affect heart rate are called chronotropic agents. Some are going to increase heart rate, some are which are positive, some are going to decrease heart rate, which are negative. So some of the positive chronotropic agents act upon the beta-1 adrenergic receptors, which doesn't mean much to you now unless you're in pharmacology right now, or until we get to Learning Plan 9 in our class, then that'll make more sense to you. Let's see here. But what's going to happen if you look at this picture kind of brings us back to the first week of class where we have a receptor on the cell. And these receptors happen to be on the heart, okay? So the beta-1 adrenergic receptors, we get a neurotransmitter that binds to these receptors, okay? And then when that happens, we release the G protein, remember that? The G protein slides over, locks into this enzyme, adenylate cyclase. We convert cyclic AMP to we convert from cyclic AMP to one of these protein kinase enzymes. Well, that particular enzyme is going to allow for more calcium channels to open. What do calcium channels do to the cardiac muscle cell? Yeah, it helps it depolarize. It helps it contract. It's going to bring it closer to, it's going to make it contract more often and a little bit more strongly. Okay, so this is what it's showing. That's a positive chronotropic agent. Now, we can have some things that block these receptors. So if we get something that is going to block this receptor site here, that would be a negative chronotropic agent. So that'd be like a beta blocker, for example. So you take a beta blocker, it'll block these sites. Now, the normal neurotransmitter can't bind to this, so then it shuts down this whole process. See? So that's how you can slow down the heart rate using a beta blocker. I think that is about it for the heart. Again, here are some graphics that kind of give you a little bit more information about these chronotropic and inotropic agents here. The inotropic agents are things that act in the myocardia to alter its contractility, like how strong it contracts, and then that's going to affect the stroke volume. I don't think any of this is really, yeah. So the chronotropic agents, this graphic here does a nice job of showing you. The chronotropic agents are going to alter the nodes, the node activity, which is going to affect heart rate, how fast the heart beats. The inotropic agents, which alter the calcium level, are going to affect stroke volume, which is how much blood is pumped per beat. And then that heart rate plus the times the stroke volume is going to give you your cardiac output. Okay, we'll stop there, take a break. We'll come back and talk a little bit about the blood vessels, and then we will call it a day.
Why don't you want to talk about PVCs?
What's that?
Why don't you want to talk about PVCs?
It's not that I don't want to talk about them. I just don't have the time. We can talk about it.
I have PVC.
You have them?
Nothing wrong with it.
No, I have them. I get them too. No, like I said, we're focusing so much on the normal stuff that we don't really venture into. It's not that it's abnormal, but it's not, you know what I mean? So,
I hooked myself up to the telemetry monitor at my work
yeah,
one day because I had literally 2 patients and my nurses were like, "Hey, let's do it." So
Yeah.
I was like, "Okay." And I have a picture where it'll show. It's not like frequent enough where it's like a problem, but
do you notice them yourself
yes.
when you're sitting there? And yeah.
When I'm laying down at night, I can feel it.
Mm-hmm.
And then when I'm sitting and I'm not doing anything, but if I have my legs crossed or my leg is higher, then I can't feel it.
Mm-hmm.
And then like if I take my pulse, my pulse skips a beat.
Mm-hmm.
So a lot of screenshots of homework. So
I've been making it a point to meditate more over the past couple of years, and I've noticed that my PVCs have gone way down the more that I've meditated.
on that one, it's right there.
Oh yeah, yeah, yeah.
And
Wow, that's cool when you see that. Wow.
yeah. So, and then I have a video on my Snapchat where you can see it, like on the top line.
Mm-hmm. Oh, there it is. Oh, yeah.
Yeah.
Wow, that's interesting. That's pretty cool. That's pretty cool.
It's really annoying.
It is. Like I said, I've when I focus on meditating more and just trying to consciously relax, I've noticed that they go down quite a bit. When I'm more stressed or fatigued or tired, they seem to be worse.
I also have like really bad migraines all the time, and like when I'm laying down trying to get rid of my headache, I notice that like when it pumps, because I can feel it. It's like a flip flop thing, and then whenever it does that, it'll like send a really big like thump in my head.
So it affects the migraines then.
Well, I've had migraines forever, so
Okay.
it's not like. And these I only noticed like 2 years ago, so.
Oh. Interesting.
Yeah.
Yeah. They're fun. Yeah, fortunately though, it's unless it's really
Unless it's like
frequent,
every
but
3 beats, then it's not a problem.
right.
It's
Right.
not.
It's more of an annoyance than.
I went to the doctor about it because I was like, okay, so this is really annoying, and like, I feel like I'm getting more headaches with it, but I don't know if it was tied in with that or not.
Mhm.
And she's like, well, I'll put you on a beta blocker, which was the medicine that she wanted to put me on was also for high blood pressure, and my blood pressure is naturally really low.
Oh, that wouldn't be good then.
So I was like, okay, sure, and then I never picked it up from the pharmacy
Yeah.
because I
Yep.
don't know.
That wouldn't be good.
She was really mean to me, so I was like, okay.
Nice, right? You go in there for help, and then that's a response.
She's like, what do you want me to do? And I'm like, I don't know. You're the doctor.
Right. Or just tell me, hey, there's nothing I can do. I know sometimes doctors are just afraid to say, I don't know, or there's not much I can do.
She wasn't the normal doctor that I go to. Mine was like jam-packed for a month, so I was like, okay. But
What do you want me to do? I don't know.
There are some doctors who just have really
she's
bad
usually nice to me though. Like I go to her before, but
She's just having an off day. Maybe she just was busy and she didn't want to.
Because we like argued
Futz
in the room.
Great. That's always wonderful. I find most are fine, but yeah.
I live in Tilton now, so I try not to go to the doctor as much because my doctor's in Plymouth. Long drive. And I already have to drive 35 minutes to go to school 3 days a week, so.
Right. It's a long enough drive. What do? Do you take Highway 10 over to 42, or what do you do to get to?
Nope. For what?
To get to school. How do you get? Thank you.
To come here?
Yeah.
I take 151, and then I take 67, and then I take X.
I meant 151, not 10. I'm sorry. 151. Yeah.
Yeah, 10 is going to Appleton.
Yeah.
151, and then I take 67 toward Kiel, and then I take X. That's through School Hill.
Yep.
And then it takes you all the way to this back road. I think it's over there, and I think it's called Westview.
Mm-hmm.
And then you turn left, and then there's the school. So.
I come from Kiel. That's why. I wonder which way you go.
Oh,
I
yeah.
usually take XX.
Well, that would be a little further.
Further south, you'd have to go south to come back.
Plus, XX, I've gone on it like once, and it's really confusing because it'll like stop here and then continue over here.
Mm-hmm.
I don't like
Yep.
that. It confuses me, so I just take what I know.
That's a good plan.
I said, I'd rather do mine.
Is everyone back? Okay.
No. I'm gonna take it tomorrow. Did you take it?
Whoops. That. We're gonna do this first. This on. This on. This on. Okay. All right. Okie dokie. All right. So similar to what we talked about with the heart, we're operating on the assumption that you remember a significant amount of your blood vessel anatomy, but I just want to hit on a couple things just to refresh your memory. When we look at the blood vessels, we have 3 layers to the blood vessels. We have an outer layer, which is called the tunica externa. We have a middle layer, which is called the tunica media, which is mostly muscle. And then we have an outer layer called the tunica externa. Forgot to mention the layers of the heart. Do you remember? Does anybody remember what the layers of the heart are called? The pericardium is on the outside, right? What's the middle muscular layer? Myocardium, and then the internal layer? Endocardium. So just make sure you know those two. Yeah. So what we're going to be looking at here primarily is just what we would call hemodynamics. So what we're looking at is measuring the velocity of blood flow and measuring the pressure of the blood that's passing through the blood vessels. So as you can see on this picture here, when we look at the blood flow velocity, what we notice is that when we have a very small cross-sectional area, that the velocity is higher. And when we open up the diameter or the available cross-sectional area, when we go to the capillary bed, then we see that the blood flow slows down quite a bit. And so what we see here is that, I mean, this is collective. This is across all the blood vessels of the body, so it's a little bit It's not exactly what we're saying. But when we take a blood vessel and we look at the diameter of the blood vessel, blood flow is going to be affected by the diameter. So when we see the cross-sectional area of the arterioles, the capillaries, venules, veins, you can see that the velocity of the blood flow through those areas is way down because the cross-sectional area. There's more available area for the blood to pass through, so it's going to be slowing down. But when we say cross-sectional area, you're talking about how wide or what diameter you have available for the blood to pass through. As it says, number 6 under 20.2, it says arteries and veins have lower cross-sectional area than capillaries because there are thousands of miles of capillaries. But you want the blood flow to be slower through the arterioles and the capillaries and the venules and so forth, because, especially when you're in the capillaries, that's where you want the exchange of gases and nutrients and so forth. So you want the flow to be much slower through those areas, so that way you can sufficiently have the exchange that you want. Okay, there's this concept called degree of vascularization, or the extent of blood vessel distribution. And so if you follow right on down 20.4, it says, the degree of vascularization or the extent of blood vessel distribution within a tissue determines the potential ability of blood delivery. So that means is the more vasculature you have, the more blood is in that organ. That's not a difficult concept to understand. The angiogenesis is the formation of new blood vessels. And sometimes when you have tumors that are developing within the body, the tumors will develop their own vasculature of the blood vessels. So it's not uncommon to see what we call tumor angiogenesis. Obviously, tumor angiogenesis is not a desirous thing, because what you're doing is you're basically giving the tumor more food, more nutrients, more oxygen to live off of. So that's why they say that the inhibition of tumor angiogenesis is an active area of cancer research. That's one of the frustrating things about cancer, is that cancer is just part of your own body. So it's this part of your body that's just growing abnormally, and abnormally fast and large, and causes problems. We have this definition called the myogenic response, and we saw this in the kidneys. Remember, in the myogenic mechanism, what happens when the flow of blood or the pressure increases? What was the response of the afferent arteriole? What's that? If we had an increase in blood pressure, then what would we see happen to the afferent arteriole? Constrict. It would constrict, yeah. So we see that. That's a normal response of arteries and the vasculature. The smooth muscle in the arteries and the arterioles especially, it's going to see constriction of the vasculature when it's stretched. So you figure if you have an increase in blood pressure, it's going to be pushing on the wall of that blood vessel, trying to open it up. So the myogenic response is to counter that by constricting. Okay, so when you stretch a blood vessel, the smooth muscle responds by constricting. Okay, that's that myogenic response that we're talking about. Bless you. So when we look at the regulation of blood flow through the vasculature, we have some things that are short-term and things that are longer-term. And when we look at vasoactive chemicals that can alter the blood flow, those are either vasodilators or vasoconstrictors. The vasodilators increase blood flow into the capillary bed. The constrictors decrease blood flow into the capillary bed. So some of the vasoconstrictors that we see in the body are prostaglandins, thromboxanes, that's under number 8. We also see some vasoactive chemicals, histamine, bradykinin, nitric oxide, and so forth. So those are vasodilators. That's why you take a what's that patch called that they put on the chest? Nitroglycerin. That's to open up the blood vessels. That's a vasodilator. Let's not talk about that one. We don't need that one. Okay, unless you want to, we can. But some of this comes around from what we were talking about in Learning Plan 4 and 5. If you see here in this table 23, we have vasodilators. These are things that are going to decrease blood pressure. So is it surprising that we see atrial natriuretic peptide here? Shouldn't be, right? And how about vasoconstrictors? Angiotensin II, aldosterone, antidiuretic hormone. Those should be very familiar to you. We already talked about the systolic versus the diastolic pressure. Systolic pressure, as it says here, is when the artery is maximally stretched during ventricular systole or contraction, and diastolic is when there's no stretching, when the artery is recoiling during ventricular diastole. So we have this, on this graphic down here, we have the changes in blood pressure as you move through the vasculature. So the highest blood pressure you're going to see is when the blood is coming out of the aorta. When you make your way to the arteries, you can see the blood pressure is dropping, and as you make your way toward the capillaries, it drops more until actually when we get to the vena cava, we're back at a zero pressure because you want the blood to enter the heart, enter the atrium, so you want a very low, if not a negative pressure there at that point to allow for the blood to get back in. Just almost lost my microphone here. All right. So sometimes you may have heard of something called the mean arterial pressure. And the mean arterial pressure is not what you find when you simply take the systolic and the diastolic and you add them together and divide them by 2. It's a little bit different of a calculation. The mean arterial pressure, it says it's the average measure of blood pressure forces on the arteries and can be found by adding the diastolic pressure to 1/3 of the pulse pressure. And your pulse pressure is the difference between the systolic and the diastolic. That's the pulse pressure. So sometimes there's a reference to the mean arterial pressure, and that's how you calculate that. So what they're measuring with the mean arterial pressure is how well are the tissues getting their blood? How well are you bringing blood to the tissues? So it's a measure of perfusion. And so that's what the map is going to basically measure. Anything from 70 to 110 millimeters mercury indicates good perfusion. So lower than that could be insufficient. High could be too much blood flow, so maybe something like edema or the accumulation of fluid somewhere in the body. All right, so we have some common pulse points of the body. These are areas that you can detect a pulse. Some of these you may be able to find on yourself. Some of these might be harder to find. it's really important that if someone suffers an injury in a certain area of the body, especially one of the extremities, that you check to make sure that there is a pulse present in those areas, because if there isn't, that could indicate some possible severe damage that could negatively affect a person. I was at a conference a couple of years ago. It was related to sports stuff, sports injuries and so forth, managing sports issues, athletes. And the person who was doing the presentation that day had talked about this football player. And he was a pretty elite high school football player. He was for sure going to college, maybe if things worked out okay, even professional caliber. And I think he broke his foot or he broke his ankle or something like that. And when he went into the hospital to get checked, they didn't check for the pulse, the dorsalis pedis artery that you see on the dorsal aspect of the foot and the posterior tibial. They didn't check either of those. And then about a day or so later, they went in and checked again. Oh, they went in and checked now because it wasn't going well, whatever it was. Happened to check, no pulse. He ended up losing his foot. And then there you go. There goes your football career. I mean, so you got to be really careful. The pulses can give you lots of information, but what they'll tell you is whether you have adequate blood flow through that area or the blood is moving through. The arteries are patent, and they're maintaining their structure to allow for the blood to pass through. So you always have to be careful and make sure that you're monitoring and measuring the blood flow at those pulse points. So they're not only for measuring the heart rate, they also do have some relevance as far as whether the blood is flowing. Sometimes, like for CPR, for example, whether the heart is contracting or not. So it's always a good idea to check the pulses in the areas that are associated with the area of injury, if there is an injury. And don't forget about the popliteal artery on the back of the knee. That's located in the posterior aspect of the knee. That's an important one too. Okay, I'm trying to think if there's... All right, so some of the factors that can affect blood flow, some of it has to do with the amount of vasoconstriction versus vasodilation. So if we dilate the blood vessels, there's less resistance to flow. We can also see an increase in cardiac output, which is going to cause a change in the pressure as well. So what we see here is that if we have an increase in cardiac output, along with vasodilation, we're going to have less resistance. If we have a decrease in cardiac output, which causes vasoconstriction, then we can see that we have greater resistance to flow. Just like we talked about with the heart, the sympathetic versus the parasympathetic divisions of the autonomic nervous system can have an effect on blood vessel diameter. So when we look at the sympathetic, which is again in green on this picture, you can see here that the sympathetic can cause either vasoconstriction or vasodilation, depending on what kind of receptors are found on the blood vessels. And we'll see that as we get onto the autonomic nervous system, that sometimes the sympathetic will have one effect on one area of the body and another effect on the other areas of the body. So, for example, when we see the alpha-1 receptors affected by the sympathetic, we're going to see contraction of blood vessels. So these are blood vessels that are closer to the surface of the body, like in the skin or the abdominal organs. Think about it. If someone's chasing you with a knife or a gun, you don't care whether you're digesting your food or not. You need blood going to your muscles and your heart to make sure that you can keep running or you can fight to save yourself, right? I mean, that makes sense. So the blood vessels that are at the skin and going to the abdominal organs, they're going to constrict. They're going to be shunting blood away from the core of the body into the muscles, so that way you can fight or you can run away. So the blood vessels with the beta 2 receptors are going to dilate and receive more blood during sympathetic stimulation. And so then we see the opposite with the parasympathetic. With the parasympathetic, then we'll see vasoconstriction for those top ones, and then we'll see vasodilation for the other ones. Okay, so here is what we see as the renin-angiotensin 2 pathway. We didn't go through it completely when we talked about it in learning plans 4 and 5. But what we see here is that we have angiotensin, which is produced by the liver, okay? And we know now that the kidneys, when they detect low blood pressure, they produce renin. What cells produce renin? Starts with a G. Granular. Yep, granular from the juxtaglomerular apparatus, right? So the granular cells release renin. Renin converts angiotensin into angiotensin 1. So angiotensin is the inactive hormone. Renin is the enzyme that will convert angiotensin to angiotensin 1. Then we have angiotensin converting enzyme, or ACE, that's found in the capillaries in the lungs. Okay. So then as angiotensin 2 passes through the capillaries and it comes into contact with ACE, we get the conversion of angiotensin 1 into angiotensin 2. And then angiotensin 2 is going to increase blood pressure. And angiotensin 2 is also going to call for the release of what other hormone? Starts with an A. Aldosterone. You got it. Nice. Good job. Okay, so when we put this all together in this picture here, like we often do, we start off talking about the cardiac output. And so if you're looking for the definition, it's a cardiac output. It's the volume of blood pumped per minute. So it's a heart rate times the stroke volume. Okay, so we see that. So if the heart rate increases, we're going to see an increased cardiac output. If it decreases, decreased cardiac output. Stroke volume increases or decreases, that's going to affect cardiac output. Over here, we see the effects of resistance on the blood vessels. So if we have vasoconstriction, that's going to be more resistance to flow, slower flow. If we have vasodilation, less resistance to flow. Whether a vessel is longer or shorter, that's going to affect resistance. So if we have longer vessels, there's more friction or more contact with the blood against that blood vessel. That's going to be more resistance. If it's shorter, less resistance. How thick is the blood? If the blood is thicker, again, more resistance. If it's thinner, less resistance. We don't need to go over that. We talked about that last time. And then here again, going through what the systolic versus diastolic pressure is, what the pulse pressure is, and so forth. All right. So just very quickly before we go, let's go through a couple things. What are the layers of the heart? Pericardium, myocardium, endocardium, from outer to inner. Yes. Okay. What are the valves of the heart? Tricuspid, which is located where? Between what chambers of the heart? Left atrium and left ventricle, right. That's the tricuspid. What's another valve? Mitral valve, which is between what two chambers? Right atrium, left atrium, left ventricle, yep. Okay, what's another valve? We did both of those. The tricuspid and mitral, both atrium and ventricular. The pulmonary semilunar, where is that located? Between what chamber and what blood vessel? Right ventricle. Right ventricle. Right ventricle and the pulmonary trunk, yes. So the right ventricle Pulmonary trunk, because the blood is leaving the right ventricle to go to the lungs. Okay, what's the other semilunar valve? Aortic, between what two structures? Left ventricle. Yep, and then the aorta. Good. Okay, good. What is a papillary muscle of the heart? It's connected to the valves and those fibers, the chordae tendineae. Very good. Yep. Okay. So take me through the blood flow through the heart. Blood enters what chamber of the heart? Right atrium. Passes through what valve? Tricuspid valve into what chamber? Right ventricle. Then out the heart to the lungs through the what valve? Pulmonary valve. Then we go to the pulmonary trunk, pulmonary arteries, bring blood back through the pulmonary veins, the back of the heart, and then the blood enters what chamber of the heart? Left atrium. Passes through what valve? Mitral valve into the left ventricle, and then that's going to leave through what valve? Aortic to the aorta. You got it. You got it. Good. Trying to think if there's anything else that I want to make sure I hit on before we leave. Yep, the pet monkey. Yep. So we got the aortic, which is to the right of the sternum, the pulmonary, which is just to the left, and then the tricuspid is down below, almost under the ribs on the right side, and then the mitral is on the left side when you're auscultating. I'm trying to think if there's anything else that we went over that I want to hit on. Okay, yeah. Tell me what is the electrical conduction system of the heart? What are the parts of the electrical conduction system of the heart? The sinoatrial node. What is it also called? Pacemaker. Yes. And then what's the next part? The AV node, atrioventricular node. And then that leads to what? The bundle of His. Okay, then down to the branches, which are called the bundle branches, then to the Purkinje fibers. Yes, Purkinje fibers, right. And tell me what makes the nodal cells autorhythmic. What is it about them that makes them autorhythmic, that they generate their own rhythm? What is it?
Sodium input, the channels.
Yeah, the sodium channels.
The sodium channel, calcium channel, and potassium channel.
Yes. So we have the voltage-gated sodium channel, which is that leaky channel that allows sodium to come in all the time, right? Leaking in, leaking in, leaking in. So we have that resting membrane potential of, I think it was minus 60. And like I said, that's not necessarily important, but for us to remember. So you have minus 60, the resting membrane potential. And then as sodium comes into the cell, it makes the inside of the cell more positive or negative? Positive, right? Until we hit threshold. And then we hit threshold, what channels open then? Calcium channels, allowing calcium to flow into the cell, making the inside much more positive until we reach 0. And then what channels are going to open then? Potassium. And we drive potassium out of the cell, making the inside of the cell more negative, getting us back to our resting membrane potential, and then the whole thing starts again. Very good. All right. And then just remember the basics of the EKG or the ECG, and we'll come back to those concepts next week when we're together. Okay, thank you very much for your time, your attention, and for participating, and we'll see you next week. If you haven't taken your test yet, good luck on your test. Hope you do well.